Some new anxiolytics and overcoming treatment-resistant depression. The topics on Audio Digest Psychiatry, Volume 24, Number 14. Speaking first are Bruce Lydlard, Professor, Director of the Psychopharmacology Unit, and Director of the Clinical Research Division, Medical University of South Carolina, Charleston. Dr. Lydlard began a review of new anxiolytics on your last issue, and he continues that review as he looks now at the monoamine oxidase inhibitors.
Many of us were excited about a year ago about the possibility of MAO inhibitors that didn't carry the same risks as the older MAO inhibitors like Parnate and Nardil. Meclobamide still is available in South America, Canada, and Europe. Brompheniramine is in a state of suspended animation right now, in that it has been halted in its development and may be purchased by another company and developed further and possibly be available. It's a 5-HT uptake inhibitor and an MAO inhibitor, though it's two mints in one. Meclobamide died kind of a sad and slow death. It just didn't show the potency that we wanted to show in social phobia and panic disorder in the studies that were done here. The nice thing about these agents, and the ones that are coming behind them hopefully will also provide us with the same kinds of advantages, is that they were polite enough to just hop off the enzyme if tyramine, which was the dietary component that can cause the hypertensive crisis, which is in high concentrations in cheese, red wine, and some other foods. So if somebody happens to ingest the wrong thing, the drug is kind enough to step aside, let the enzyme metabolize the tyramine, and then go back, because of its reversibility, then to go back as an inhibitor of the enzyme. Very nice side effects profiles compared to the predecessors. These agents are potentially useful across a broad variety of disorders. We need to get another one. Moving to the future, the concept of gastrointestinal motility and arousal is one that we certainly see in our anxious patients a lot. A lot of irritable bowel syndrome, for example, in patients with anxiety or mood disorders. We have gotten some new information about what might mediate this kind of response. And one of those is a neuropeptide called cholecystokinin, which we have found is a very potent anxiogenic compound. Looks kind of like the gastrin molecule, and we're say, well, wait a minute, this is a gut peptide. What are you talking about? In fact, most of the peptides and neurotransmitters we find in the brain were isolated first in the gastrointestinal system, in the enteric nervous system. Part of this molecule is a very potent anxiogenic compound. This is the CCK tetrapeptide form of this hormone. It exists as a neurotransmitter in the brain, interacts with specific receptors, and when injected in microgram quantities into humans will induce panic attacks very much like the ones that people experience spontaneously. It's ubiquitous, modulates a variety of neurotransmitters and other neuroactive compounds in the brain, often co-localized with them in the neurons, in fact. Was discovered when a guy was doing work in sheep, giving a gastrin-like substance into sheep brain, and found that when they put them in the lateral ventricles that they would have foot stamping and vocalization that were not normally associated with satiety in sheep. What we found is that this is a compound which has high receptor concentrations in a number of important brain areas, interacts with GABA in the cortex and other important brain areas, and also that there's a functional antagonism both between another form of it, the 8-peptide form, but between cholecystokinin and the benzodiazepines, both in neuronal tissue and in the periphery, so that there are mutually antagonistic effects between compounds that mediate their effects. Two types of receptors, A receptor for alimentary tract or GI tract, and then the B receptor for brain. And both these agents cause anxiety. One in particular seems to mediate anxiety, while one is more involved with other things. Satiety is one of them. They also appear to be mutually antagonistic in some ways, such as in modulating endogenous opioid function, for example. We know that when you give CCK4 or penagastrin, which is just one more amino acid, into the brain or vein, it makes animals afraid, and it also causes panic attacks in humans. In patients with panic disorder, 15 micrograms will do it. In patients without any disorder, about 50 micrograms will do it. So there is basically a difference in sensitivity, it looks like. But it is now being looked at by us and others as a model for panic disorder. And if you give a selective cholecystokinin B antagonist before you give this agent into the vein of human volunteers at a dose which would give 90% panic response rate At 10 milligrams, you can drop that by about 2/3, and at 50 milligrams, it abolishes the panic attacks if administered before one is given this peptide infusion. So a very nice demonstration of the effects that blocking this CCK-induced anxiety. Some of them are gone out of the developmental pipeline, but there are others coming behind them. This is largely for technical reasons, the way they make the pills and so on. But this is a group of agents that shows a lot of promise. We think that the peptide may work by stimulating receptors in parts of the brain that are not completely protected by the blood-brain barrier. And we know the antagonism part came because when you give CCKB stimulation, it excites neurons in this nucleus tractus solitarius, while the A receptor stimulants will actually do the opposite. And when you do inject these, you'll see effects that are quite commonly observed in autonomic arousal. We looked at CCK8 in the spinal fluid of patients with panic disorder and found that it was reduced. And if you think back about what I said about inhibitory, because we thought, well, this doesn't make any sense, we'd expect it to be more. But if you think about the inhibitory or mutual antagonism effects, less 8 might mean more 4 in some form. We don't really understand it completely yet. But this is one of the first positive findings in the biology of panic disorders, CSF studies, that we found over the 10 years or so. So maybe patients with panic and other anxiety disorders have sensitivity to these things, and they have abnormally sensitive receptors, or they make abnormal amounts of one or the other of these agents, or whether it's some interaction with abnormal benzodiazepine receptors in patients with panic disorder isn't clear. If these agents ever make it to the marketplace, compared to the benzodiazepines, we're going to see that they're both anxiolytic and orally effective, not sedating. At least the ones that we've seen so far don't have the muscle relaxant and ataxia factor, do not potentiate alcohol, do not themselves cause physical dependence, and in fact can suppress, at least in animal models, withdrawal from benzodiazepines and alcohol. So if this is true, we're going to have a group of very interesting new compounds. So let's cross our fingers for that. Just a little aside, as talked about ondansetron earlier, this agent will prevent CCK peptides from causing anxiety, at least in animal models. So it looks as though there may be some modulating effect from the 5-HT3 receptor. We also know that if you have a needle stuck in a rat's brain that's walking around and you stimulate the release of cholecystokinin, you can attenuate that significantly by pre-treating with this 5-HT3 antagonist. So it looks as though there's a connection there. And coming in the home stretch, some other possibilities for treatment, one of which is antagonists to CRF, which is corticotropin releasing factor. You've all heard of the dexamethasone suppression test, and somewhere way back upstream is abnormal production and release of a hormone that appears to be stress-related called CRF, which sets into motion that cascade of events that leads to increased cortisol in depressed and possibly in anxious people. We know that benzodiazepines, for example, will shut off the release of CRF. Well, there's one that was found in the thymus gland. And I always thought, what an odd name, for the thymus, because that's sort of, we think about thymoleptics and mood, and I always thought to myself, what a weird thing to call a lymph gland. Well, in fact, a compound that was isolated from the lymph gland, 50 peptides, thymopoietin, actually antagonizes CRF. And there have now been some variants of this developed, one of which was a pentapeptide, supposedly developed effective orally, taken once or twice a week with no side effects, that had promised to be an effective antidepressant and anxiolytic. So we've got some new stuff happening. There's been a lot happening. What we need is better anxiolytics, non-benzodiazepine types, such as the CCK antagonists that are not abusable, that act quickly, that don't have rebound, that are safe, and don't interact with other medicines, and that are reasonable in terms of their side effects profiles. We're not there yet, but each new day brings new hope, I think. Other agents that might modulate both mood and anxiety disorders would be combination agents that are 5-HT2 antagonists and 5-HT1A agonists. And the broad spectrum, although I'm not either that much of a believer in the venlafaxine being better because of the uptake inhibition story, but REMAs would be another group, as the old MAO inhibitors are, at broad spectrum effects. And there may be something there, we'll have to see. And of course, these peptide active agents that we have, at least in the developmental pipeline that we hope to study soon, may also be good additions to our armamentarium. It would behoove us to try to find agents that are selective, perfect for our patients, that we have a large number of these on the golden key ring in the office. And of course, we're not there or even close to it. But hopefully, over time, we'll get closer to this goal.
Now Overcoming Treatment-Resistant Depression by Andrew A. Nierenberg, Assistant Professor at Harvard and Associate Director of the Depression Research Program at Massachusetts General Hospital.
We tell our patients that they'll take these antidepressants and they'll get better, and what we fail to tell them is that if you really look carefully at the data, maybe half of them will really get all the way better, maybe, and that maybe another 20 to 30% will get somewhat better, and maybe 10 to 15% will really not budge at all, but will manage to give them side effects. We get more sophisticated in psychiatry and try to have some rational polypharmacy or rational reasons to use different drugs. We have yet really to come up with very good paradigms about why people respond and why they don't respond to the antidepressants that we have. So one of the problems is psychiatric comorbidity. And psychiatric comorbidity can complicate response and recovery. People can have alcohol and substance abuse, post-traumatic stress disorder, panic disorder, this fuzzy thing in the DSM-4 appendix about depressive personality. I believe we're still allowed to use this word, even though it's been purged from our official vocabulary, neurosis, personality disorders, and Axis 4. With alcohol and substance abuse, if you look carefully at the literature of placebo-controlled trials and things like that, people can't be in it if they're actively abusing alcohol or substance abuse. So they're just cut out of all the studies to begin with. In practice, we see these people all the time, and it really does make things harder. Now, I'm sure you all know that if somebody has active alcohol and or substance abuse, then all bets are off in terms of response to antidepressants. What you may not know is what my colleague John Worthington has recently found, and that is if patients use alcohol, they don't abuse it, but if they use it, even a couple of drinks a week, and they're depressed, they don't respond as well to the antidepressants. He will be presenting that data in Miami at the APA. So I don't have it here, but it really is quite remarkable and a robust predictor of how well somebody does. Based on that data, my colleagues and I are recommending to depressed patients they really be alcohol-free and not drink anything at all. Some people complain about it, but some people don't. But if there's one thing you take away from my talk this morning, it may be reasonable to tell people not to drink if they're depressed and they're taking an antidepressant. Right? Their Hamilton scores are all higher than those who don't drink at all. The other thing that he found in terms of use and abuse is that if patients smoke, they actually do better than the patients who don't smoke. It seems to help with their anxiety. I wouldn't recommend telling people to start to smoke. There may be some problems with that. You'll start to see a series of papers that John Worthington will be publishing within the next 12 months. It should come out. Post-traumatic stress disorder is always in the news, and now do people remember something real? Do they remember something false? What's real and what's not? For the data that exists on post-traumatic stress disorder, at least Judith Herman claims that if these patients are depressed, they really need a very complex 3-year multimodal group and individual behavioral, cognitive, stress management, very complicated therapy, and they don't respond that well to the antidepressants. And that's certainly consistent with my clinical experience. Michael Thace has found that if patients have sub-threshold panic disorder, they respond preferentially to monoamine oxidase as opposed to the tricyclics, and the SSRIs probably are as good as the MAOIs for that. I won't talk about depressive personality because I don't understand it at all, but with neurosis, believe it or not, neurosis, and no matter how you define it or measure it, is the single best predictor of non-response. And if you look at all across studies, if you look at the Eysenck personality inventories and things like that, if you measure neurosis, a chronic proclivity to overreact to stress and to emotional stimuli and to be neurotic, Woody Allen-esque, you don't respond that well. And personality disorders is also kind of fuzzy because it's very hard to measure personality disorders. And Maurizio Fava and I have just looked at a huge database of over 400 patients all entered into our clinical trials. And believe it or not, personality disorder did not have any predictive power of who was and who was not going to respond to an SSRI. Now remember, these are patients who came into trials, so their personality disorders can't be so bad that they couldn't cooperate with the study. So take it with a grain of salt. And I'll tell you about different types of stress later on. There's dysthymia and this dysthymic disorder. Those patients who have a major depression superimposed on a chronic negative bleak, black, gloomy, despondent, irritable background. And in the old literature, it said that if you had double depression, then in fact you didn't respond as well if you had single depression, if you had depression alone. And we've just looked at the database now of about 250 people, all of who've been entered into an open clinical trial of fluoxetine 20 milligrams a day, and it had no predictive power whatsoever. So it might be clinical lure more than anything else. Well, as you all know, the SSRIs have become de facto standard antidepressants and more or less have displaced the tricyclics as treatment of first choice because they work, they're easy to use, they have a favorable adverse drug event profile, and they're safe in overdose. And they've had profound media transformations. It was the miracle drug, the drug that made you into a homicidal killer, the drug that you listened to, and the designer personality drug. And really listening to Prozac has had an enormous impact on the public perception of antidepressants. People still aren't treated enough, but at least it's not such a big deal if you're taking one. And if you look at the internet, you'll find actually Prozac discussion groups, Zoloft discussion groups. I'm serious. Yeah, there's a whole depression group, and they talk about these things all the time. So it's been extremely successful. There are now 4 SSRIs that are on the American market. So you have fluoxetine, sertraline, fluvoxamine, and paroxetine, with fluvoxamine being approved only for OCD, but there's a long history in Europe of it being used as an antidepressant. What's now clear is that there's nothing wrong with what it works on, the transport molecule that is inhibited by the SSRIs, this particular protein in depressed patients. So there's nothing wrong actually with the uptake molecule itself. It seems to be the same in people depressed versus people who are not. So even though it's the site of action and then there are all these other cascade of reactions that go on past that, this is it. It's no longer a little black box that you see on a membrane, now well characterized. Many patients are helped by these drugs, but others fail either to respond or sustain a response. So maybe 40 to 50% have a complete remission. That would be a 17-item Hamilton of 7 or less, and somebody who you would really consider to be normal. However, even in those who have full response, residual symptoms are common. They're not quite normal in many ways. 10 to 15% of patients have no response at all. They simply don't budge, and that seems to be the same across all the antidepressants. There's this core group of people who simply do not budge. And 20% to 30% can relapse really within 6 months to a year. Again, if you look carefully at the literature, and if you talk to anybody who treats patients more than just for 6 weeks, that patients can get sick again. And I'll talk about that later on. That's breakthrough depression, tachyphylaxis, that sort of thing. So it leaves us with a small proportion, but a large number of people who just consistently, persistently have problems. And that's why it's of interest to me as a clinician of, well, what do you do with these people? Well, what you do with them, the approach to them, has really been extrapolated from the literature on the tricyclics, although there is better data that's being generated daily. There are essentially 4 things that can be done, and Larry Price from Yale has categorized these, and I think it's very helpful to think of it this way. You optimize what you're doing, you augment it, and then there's some overlap with combining things. So you combine different antidepressants for perhaps different effects or different types of antidepressants. Again, there's an overlap with augmentation. I'll go through this in detail. And then there's substitution. Stop doing what you're doing and do something else. So that's all we do. And you can do all of these together or one, and we'll go through each one of these. To optimize a trial of an SSRI, you give enough stuff for a long enough time. It's very simple, except there are some problems. How much is enough? How long is adequate? If indicated, when should you start increasing the dose? If the trial should be extended, how do you know when to stop, when to say that's been enough? And what are the data for any optimization strategy? How much is enough is a real problem for using the SSRIs because there's no dose-response relationship. There's no dose-response or blood level relationship that has been shown in any study. So how do you know when you should jack the dose up? And is it worthwhile doing it? The duration of an adequate trial is extraordinarily complex. We were originally taught in the early 70s and mid-70s that really it was 3 to 4 weeks. And then Quitkin in 1984 published a very influential and very complicated paper that said that 6 weeks is an adequate trial. And in fact, in that paper, Quitkin said that if you don't respond by week 4, that you have a 40% chance of responding by week 6 if you extend the trial. However, it took him 3 weeks to get up to adequate doses. And there's some problems with that, but we don't have to go into the details. Well, what I'd like to show you is some data that's in press. My colleagues and I asked a question, and that is if you don't budge at all to 20 milligrams of fluoxetine by weeks 2, 4, or 6, what's the probability that you're going to respond by week 8? We realized that nobody knew. So we decided to look at the data that we have. And we found that early non-response to fluoxetine actually predicts an 8-week outcome. If you have no response at week 2, you have less than a 40% chance of going on and becoming a responder by week 8. If you have no response at all by week 4, you have an 18% chance of responding by week 8. And if you haven't budged by week 6, you have a 6% chance of responding by week 8 to a fixed dose of 20 milligrams a day of fluoxetine. And then you can see you have this stepping up at each point in terms of the subsequent probability of response, such that if you have a good response by week 2, that's good news. And it turns out that the majority of the patients who have good responses at each time point go on and have that improvement by week 8. Based on these data, my colleagues and I are recommending that certainly if you're not budging between weeks 4 and 6 to a fixed dose, at least of fluoxetine, you better start doing something else. And whether that something else is jacking up the dose, augmenting, or combining, you got to do something else. It's probably premature to stop doing it and go to do something else. But these are the only data that I'm aware of that indicate when you should start really to intervene if somebody's not budging at all. If somebody's improving a little bit, at least you have some hope that they'll get better. Augmentation of an optimized SSRI trial is popular and it's simple to do. The data are limited, so you should be aware of that. And I'll just talk about 3 things. There are many others, but I'm going to just talk about 3. One is lithium, the other is thyroid, and the third are stimulants. Now, in the land of lithium here, lithium augmentation makes a lot of aesthetic sense. Lithium increases the presynaptic formation, storage, and release of serotonin, and you're doing it on a system that's already primed for that. And with the SSRIs, it's based on case series and a few controlled trials, and until recently, there really weren't any placebo-controlled trials, but I'll tell you the data on that. One is a study by Ontiveros and Fontaine, and they compared lithium augmentation of dizipramine to lithium augmentation of fluoxetine. They had 30 patients in each group. These were 30 patients who failed an adequate trial of either dizipramine or fluoxetine. So they all failed an adequate trial, and they had 60% who had a reasonable improvement in each group. But of great interest, the fluoxetine patients responded faster. They responded within the first 2 weeks, whereas with the dizipramine patients, it took them 3 to 4 weeks to respond. 33% of the lithium augmentation responders who failed fluoxetine relapsed 14 weeks later, and none of the lithium augmentation responders to dizipramine relapsed in that same time frame. Curious. Maybe there's something different going on. And this is the most important study that's been published to date by Katona, that's K-A-T-O-N-A, and colleagues in the British Journal of Psychiatry about 3 months ago. And they did a placebo-controlled trial of lithium augmentation of fluoxetine or lofepramine. Lofepramine's not available here, but the important thing is fluoxetine. And they found 2 important things. One is that placebo and fluoxetine certainly didn't do as well. These are Hamilton scores, so going down is better, as those who were on the lithium. So there's a clear difference between placebo and adding lithium, with lithium patients doing better. But one of the more important things they found is that if you take out The patients who had inadequate lithium levels, it looks even much better. Katona and colleagues finally have provided us with really very important data on it. This is extrapolated from the literature on lithium augmentation of the tricyclics from Michael Face and colleagues in 1989. They took 20 patients who failed 12 weeks of full whopping doses of imipramine with adequate blood levels and added lithium openly. Found that within a week, nobody really did that well, and you started to see the proportion of responders rise between weeks 2 and 3, and then it leveled off. Now, most clinicians will not persist with a trial of lithium augmentation beyond 4 weeks. Yet, what Mike found was that a lot of people started to respond only by the 4th week. And that, in fact, once he waited for 6 weeks, the response rate was on the order of 60%. Of those who responded to lithium augmentation, 40% responded between weeks 4 and 6. So this was uncontrolled, so you have to take it with a grain of salt. But I'll tell you about a trial doing later that may show it. If you remember, I did mention possible side effects. When you start to combine medications, you have to start worrying about really complex interactions and an increased risk of developing side effects. Now, lithium augmentation has some risk of adverse drug reactions, but these are actually rare. There are scattered reports of changes in mental status. There are scattered reports of a serotonin syndrome where people get hyperpyrexic, muscle irritability, tremors, convulsions, coma, death, but it's extraordinarily rare.
Dr. Nierenberg's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 24, Number 14, returns to Andrew A. Nierenberg on overcoming treatment-resistant depression.
With the tricyclics, lithium augmentation has been known to precipitate mania, which is curious. There are at least 2 reports of that in the literature, but again, that's extraordinarily rare. It seems counterintuitive, except if you have a big presynaptic push of serotonin, maybe that would be the mechanism for that before the whole system can adapt to that big push. Thyroid augmentation of the SSRIs have almost no data that I'm aware of. There are a few scattered case series in letters to the editor. There were no controlled trials that I'm aware of. I know people do it, and it's probably not unreasonable to do, but the data's not there. Thyroid augmentation is usually well tolerated, few adverse drug reactions, sweating, tachycardia, tremors, anxiety, and if you're going to give it for a long period of time, at least there's a question of osteoporosis. Jaffe and colleagues found, at least for the tricyclics, that lithium and thyroid augmentation were equivalent. Both were better than placebo, and both worked at about 60%, but this was an acute trial and there were no follow-up data at all. This was 2 years ago, May, in the Archives of General Psychiatry. Now, one thing that's curious is why do people choose one thing over another? And I asked 118 psychiatrists some years ago what they would do with a patient who failed 4 weeks of nortriptyline at a blood level of 150 nanograms per ml. What would they do with them? And at that time, they overwhelmingly chose to add lithium. I won't go through this, it's not that relevant, but only 1 out of 118 chose to add thyroid at that time. And it may actually be a geographical bias. In the Northeast, people like lithium. And in the Southeast, people like thyroid. And now the data really suggests there may be no big difference between the two, but there just may be geographical variations. I'd actually like to ask you, how many people used lithium augmentation? How many people used thyroid? Substantially less. It's interesting. The data supports both, but they're substantially less. I think in a way we're much more comfortable with lithium because we use it for other disorders. So it's just using another thing. And thyroid, what are you doing? Thyroid levels, who knows? But at least the data says that they're equivalent. Stimulants and dopaminergic agents are intriguing for the lack of data, and at least at Mass General, widespread use as adjuncts. And there's a dopaminergic hypothesis of depression that was elegantly reviewed by Kapoor and Mann, that's K-A-P-U-R, Kapoor and Mann in Biological Psychiatry about 2 years ago. On balance, it seems like there's a little bit more evidence for it than against it, but it's really very mixed. Clinicians at our shop tend to use methylphenidate, pemolin, dexedrine, bromocriptine, and pergolide. That's basically the list. If you're going to use dexedrine, you have to document very carefully why you're doing it, so that when the regulators come after you, you can tell them why and they won't take away your license, like they did to a colleague of ours in Western New York State, who was the only sort of expert psychopharmacologist, and they didn't like what he was doing with prescribing too much of this stuff for very, very ill refractory patients, and they pulled his license. Bromocriptine has been touted by Don Klein at Columbia to treat a subtle syndrome of apathy that he has observed with some patients who respond to SSRIs. It's not a recurrence of the depression. It's very different. It's just they don't care about things so much anymore, either good or bad. And he has a hypothesis that this is somewhat dopaminergic in nature and gives a little bit of bromocriptine and finds that that's helpful. This is limited by nausea. That's the rate-limiting problem with that. The same thing with pergolide. The same sort of thing. We wondered, does this stuff work because these patients also have attention deficit hyperactivity disorder? So my colleague Jonathan Alpert asked, is ADHD comorbid with depression? So we looked at 100 consecutive outpatient subjects, used the Kitty SADS ADHD module to diagnose it, and we found that using strict criteria, about 8% met criteria, using a little looser criteria, instead of 8 out of 14, use 6 out of 14 criteria, 12% met ADHD criteria. And to our amazement, we found no difference between those with and those without ADHD in terms of the age of onset of depression, in terms of the chronicity of it, the duration of it, or the response to fluoxetine 20 milligrams a day. So we've been trying to get that into press, and you may see that around. Combination treatments, the thing that sort of overlaps with augmentation. There's tricyclics, trazodone, bupropion, buspirone, even neuroleptics, just to name a few. I'll tell you the tricyclic story in a moment. It's an interesting story. Trazodone has been discovered by psychiatrists as maybe being the best hypnotic we've got. And so it's at least popular in Boston for people to combine trazodone with SSRIs. Is it popular here too? People do it? Yeah. There's actually a placebo-controlled, double-blind crossover trial of using trazodone for antidepressant-associated insomnia that my colleagues and I published last July in the American Journal, so it does seem to work. It helped in 67%, placebo helped in 19%. Whether or not it actually works as an augmentation, combination, something like that, is actually not entirely clear. And in using it a lot for antidepressant-associated insomnia, I'm not impressed with how well it can work as a combination to make non-responders into responders. I'll tell you a little bit about bupropion in a minute. That's also a funny story. Buspirone is becoming increasingly popular as an augmentation, and to quote my boss, Jerry Rosenbaum, who says that buspirone is everything you've wanted in an anxiolytic except efficacy. So people like to add it, and it doesn't do a lot of harm, and maybe it does a little good, and now there are a couple of case series that support it, no controlled trials yet. And then there are those patients who are so anxious and agitated and don't respond to benzodiazepines, they don't respond to sedating antidepressants, they don't respond to buspirone if you add it or use it. And some people use these low doses of neuroleptics to manage those and find they get a lot better even if they're not psychotic, with a full awareness of the risk of tardive dyskinesia. All right, tricyclics. Tricyclic antidepressants added to an ongoing but failed SSRI trial is a popular antidepressant cocktail. Preclinically, you actually get a more rapid downregulation of beta-adrenergic receptors, and I'm sure you're all very excited about that. There are uncontrolled data for non-responders, uncontrolled data for increasing the speed of response, and there are questions about how much tricyclic should be added, what's an adequate combination trial, and how long should the combination be continued. This business about the speed of beta-adrenergic receptor downregulation is associated with a hypothesis that to get antidepressant response, you have to have beta-adrenergic receptor downregulation, and usually that's delayed. The onset of beta-adrenergic downregulation is usually 2 to 3 weeks, and if you do them together, Barron and colleagues found in an obscure European psychiatric journal that this really happens much more quickly with a combination than with either dizipramine or fluoxetine alone. That's kind of curious. Craig Nelson has published uncontrolled data for non-responders and now has preliminary controlled data for actually increasing the speed of response. That is, he's taking inpatients double-blind on the combination versus one drug alone and finding that patients respond faster to the combination. It's important to note that he's using enough dizipramine to get adequate levels of dizipramine with the combination with fluoxetine. And again, I have to state and remind you that fluoxetine will drive the levels up of dizipramine, so you have to do it a little carefully. And that's where this comes in. How much should you use? At least Craig Nelson claims you got to use adequate tricyclic levels in order to speed up the response. How long to do it really is totally unclear, and how long you have to continue the combination is unclear. Because some people will actually try to simplify the regimen, take away the thing that's either augmenting or combining to see if you sustain the response. Fava and Rosenbaum now have published data that compared lithium augmentation, adding a tricyclic, and increasing the dose of a failed trial of fluoxetine 20 milligrams a day. And take what I'm going to say with a big grain of salt, because the differences are not statistically significant because the numbers were small. All right, these are not statistically significant differences, but they're intriguing. Increasing the dose from 20 to 40 was superior to augmentation. Response rate on the order of 53%. Lithium augmentation was superior to adding a tricyclic on the order of 29% versus 23%. And we're doing this humongous NIMH trial that I'll tell you about at the end to try to see if this is in fact true. Mark Pollack, my colleague down the hall, reported on the combination of fluoxetine and bupropion along with Larry Labate in the Annals of Clinical Psychiatry. And actually added bupropion to fluoxetine for a male who had sexual dysfunction, who had a partial response to fluoxetine, and found that it actually augmented the fluoxetine. Added 75 to 150 milligrams a day. So again, there's very little data to support this, but I just want to let you know about it, that it's become rather common practice, at least in the psychopharmacology unit. You heard yesterday from Jeff Jefferson that bupropion's action is probably mostly on norepinephrine. So maybe this is congruent with the data on combining dizipramine and fluoxetine. Kind of curious. The waters may be murky for data on substitution strategies. With bupropion, there's only one study I'm aware of that looked at patients who had intolerant sexual dysfunction, Jonathan Cole and people. Now, venlafaxine is a profile similar to anafranil. Mike Thesis called it anafranil light. I like that. But without the anticholinergic and antihistaminergic effects. It's a weak inhibitor of norepinephrine and 5-HT relative to the potency of other drugs in terms of its chemical preclinical measures. But it's as effective as other antidepressants. And we just had this modest success with resistant patients that I'll show you in a moment. Dose range 75 to 375. Side effects, nausea, insomnia, sedation, increased blood pressure, rarely. Just one comment on the nausea that people have. I think the company made a mistake with too high initial dosing. And if you whomp people with this stuff, they're going to throw up. But if you're gentle with it and you start low and gradually go up, people seem to tolerate it pretty well. The trick isn't starting low and not with what they recommend with 75 milligrams a day to begin with. And I think that's why it's actually running into some trouble with the nausea. This is what we found with the venlafaxine. We had 70 patients. This was done John Feiner, Jonathan Cole, and myself, 2 sites. We had very stringent definitions of response so that full responders had to have a final Hamilton of 7 or less. Partial responders had to have a 50% improvement, which in most studies is considered to be a full response. These patients failed a minimum of 3 adequate trials from at least 2 different classes of antidepressants with at least 1 attempt at augmentation, or they could fail ECT plus 2 trials plus 1 failed attempt at augmentation. At the site that Jonathan Cole and I did at McLean Hospital, the mean number of failed trials was 10. So these were sick puppies, and their Hamiltons were in the order of in the 30s, so they were all severely ill. We found nobody budged in the first week, and we did dose these people rather aggressively, but we started with 50 for 3 days and then 75 for 3 days. By the second week, we were up to 150 to 225. By the third week, we were up to 375. So again, dosed them very aggressively. A couple of people responded in the second week, a couple more. By the 4th week, we actually had about 18% responders or so, and we were pretty happy with that. That wasn't too bad. We figured that maybe we'd be lucky if 20% responded. Kept them on it for longer and found that about 30% or so had a really pretty good response. Extended it out to 12 weeks and it went a little higher, maybe 33, 35%. So we had about a third of patients who acutely had really done terribly with other things who did reasonably well with venlafaxine. We did follow these people out for 3 months and found that about half of them lost it, which wasn't surprising to me because in treating these people, sometimes you're lucky if you buy them 2 or 3 months. In other studies of venlafaxine, so far follow-up studies seem to be that it's as good as any other medication. Nifazodone, I think you were told about, chemically related to trazodone, the advantage of lack of sedation, no sexual side effects yet. It has interesting combined actions, an SSRI plus 5-HT2 antagonism, downregulates the post-5-HT2 receptors. Dosing is really 300 to 600. No data yet on patients who are resistant, so we don't know. We'll see. Meclobamide is interesting. Has anybody here ever used meclobamide at all? It's available in Canada, and it's actually very easy to get, and it's legal to get it. But it's a short-acting, reversible monoamine oxidase inhibitor of A. It's called a reversible inhibitor of monoamine oxidase A and is in a class called RIMA, R-I-M-A, reversible inhibitor of monoamine oxidase A. And to review, monoamine oxidase A affects norepinephrine, 5-HT dopamine, B affects dopamine, phenylethylamine. There are no dietary restrictions with it. It's not so bad. Side effects are dry mouth, somnolence, headache, dizziness, agitation. And to get it, all you need to do is find a pharmacy that will send it down across the border. And you send them a prescription, the patient sends them money, they send them the drug. And it's reasonable stuff. Good news is there are really many options. And that you can optimize, you can augment, you can combine, or you can substitute. The bad news is that there's really limited data to help with the treatment decisions. And the real bottom line is balancing the benefits and the risks with your patients. Balancing the benefits and risks and negotiating it with your patient turns out to be the best bottom line.
Dr. Nierenberg answers questions relayed to him by David Kanselnick.
We start with a question for Dr. Nierenberg, wondering what the impact is of depressive subtypes on treatment-resistant depression and whether you would do something different as a second or third line treatment for patients with one subtype versus another.
Mauricio Fava and I have just looked at about 400 patients who were treated prospectively with 20 milligrams a day of fluoxetine, 8 weeks, very similar protocols that we did. And no matter how you cut the data, no matter how you defined a subtype, no matter if you looked at pure atypical versus non-atypical, if you looked at pure atypical versus DSM-3R or DSM-4 melancholia, DSM-4 melancholia versus non-DSM-3R melancholia versus non, anxious depression, irritable depression, anger attacks, no difference. No difference whatsoever in terms of subtypes and at least response to one SSRI. The only place it seems to hold up a bit is the monoamine oxidase inhibitors have a broader range of action and seem to work better than the tricyclics and atypicals. But otherwise, there's no distinction at all. In trying to think about, well, do you use the MAOIs if you have an atypical, or do you use the SSRIs, and trying to balance the benefits and risks, because you all know the MAOIs are a pain in the neck to use and a pain in the neck for our patients to take. There are no studies I'm aware of that do head-to-head of an MAOI versus an SSRI. There are a few studies that actually look at SSRIs in atypical, and it looks like it's promising.
There are a number of questions about use of Ritalin and stimulants. The question is dosing, duration, and how much evidence is there beyond acute treatment for long-term efficacy for stimulants?
There's very little evidence whatsoever to use the stimulants. There are some very good reviews, two in particular, one by Sattel and Nelson in Journal of Clinical Psychiatry about 4 years ago now. Another one by Jonathan Cole, actually in the archives, about 6 years ago. And they go through all of the evidence that's published to use the stimulants, and there's not a lot. There are no really good studies of using it as an adjunct. The other thing is that, according to my colleagues in the Child Psychopharm unit, Joe Biederman and Tim Willens, they say you can actually use between 1 and 2 milligrams per kilogram of methylphenidate, which, if you think about it, is a whopping dose. Right, you have the usual average person, although they don't exist, but the usual average person is 70 kilograms. You're talking about 70 to 140 milligrams, which is enormous. I usually haven't gone above 60. That's the highest that I've gone with either methylphenidate or with dexedrine. Usually I don't go a lot higher than that. I get a little nervous.
Dr. Sachs.
One of the things about dosing, having heard the same thing from our colleagues in child psychiatry that Annie's pointing out, is children often take higher doses of practically everything. That includes drugs metabolized by the liver as well as the kidney. So it's common for lithium doses to be higher and for antidepressant doses, and practically everything else kids will tolerate better. So when you go from hearing they gave 1 to 2 milligrams per kilogram to kids to your adult patients, you can quickly get into big trouble.
Right. And also I want to emphasize that if you do end up using the stimulants, you have to be very cautious. You have to document very carefully why you're doing it, and you better make sure something else failed, and it's usually a good idea to get a second opinion from a colleague. It's potentially dangerous stuff, so you really have to be cautious.
There were a number of questions on use of lithium for augmentation, and you mentioned a little bit about studies using therapeutic doses and treating for longer. But for most patients, do you really need to reach a therapeutic level? Should you try to shoot for that? Do you give lower doses first and then go up? What approach do you recommend?
It depends how conservative you want to be. If you want to be conservative, you should be at least above 0.6. And if you want to minimize side effects, to have patients hover around 0.6. If you want to be more conservative, there should be 0.8 and higher. I didn't get a chance to talk about the study that we're doing with Maurizio Fava and Jerry Rosenbaum, and that is we're treating 500 patients prospectively with fluoxetine 20 milligrams a day to get non-responders, and taking the non-responders and giving them either a higher dose of fluoxetine or 50 milligrams of dizipramine or 600 milligrams of lithium. We're currently up to patient 250. We're halfway through the study. Actually, we'll know what's better, but with a fixed dose of lithium, we may have some data on do levels really make a difference. It's hard to know directly from the studies, except from the recent study by Katona, that the really low levels, they don't work. And that was shown in another study by Stern and Bernhardt in the British Journal of Psychiatry. And they used teeny-weeny levels. They used 250 milligrams, compared it to 750, compared that to placebo, and the 250 was no better than placebo. The 750 worked reasonably well. So it's probably best to get a level of at least 0.6. That's probably the most reasonable thing to do.
Question about patients who have depression probably secondary to a neurologic disorder, whether it be Parkinson's or having had a stroke, choice of medications, and also how long would you treat them, because the underlying cause is clearly there and probably not going away.
Well, during my training, I was taught that if a patient has an underlying medical illness and a depression, if you treat the underlying medical illness, the depression goes away. It's not my experience. It's still there. You also may know that up to 40% of patients who have stroke can have a real major depression, post-stroke major depression. In Parkinson's, it's also, I think it's as high as 40%. It turns out, at least to my reading of the literature, and I'd be interested to know if anybody knows differently, I don't know of any studies of SSRIs in post-stroke depression that have been published yet. Just case reports. Just case reports here and there. It depends on what else is going on. A lot of people with strokes will also have cardiac diseases. I mean, one of the good things about the new drugs that we have is that it's really rather free of cardiac toxicity. I think it's the same thing with really the Parkinsonian sort of thing. I don't think there's any particular thing I'd choose over any other for those, just what they could tolerate and what seems to go along with the other medications that they're taking.
Wondering about carbamazepine, we have a sense that there is enzyme induction and that levels go down, and the question is how long does that keep happening? And going along with that, for bipolar patients, how frequently do you really monitor their CBC and levels? If you do what the PDR says, you become very unenthusiastic about using it.
Right. For carbamazepine, I think you have to look and expect that you're going to see this dip, usually in the 8 to 12 week range. You might see it a little earlier, a little later in some patients. Once you go up, very often that's the one and only time it will happen, but sometimes after you increase the dose, you will see it again. So as a rule, what we do, when we start carbamazepine, we follow the blood levels every week until the patient is stable. And then we're going to get blood levels every 2 to 4 weeks the next several months. Usually that takes us past the 3rd or 4th month, and we've seen this period. After that, it's once a month for 6 months, and then every 6 to 12 months. Usually when you have seen the blood level stay within a given range for 6 months or more, you're out of the woods with the enzyme induction. We're talking about the CBC. It's almost entirely medical legal. If you listen to neurologists, they love to poke fun at us. They would prescribe carbamazepine and see you in 2 months, kind of thing. Now, they're treating different patients, and the drug has approval for that indication. So I think that somewhere in between, let's do it every week forever, and doing what the neurologists do, there's wisdom in the middle ground. And what we do at the beginning, we're getting biweekly CBCs. But after the patient's stable, we think it's reasonable every other month to be checking the CBC, because you're not going to pick up bone marrow suppression unless you're very lucky, and by then it's usually too late. The point really is so that the lawyer looks and sees that you're thoughtful and kind to the patient, and you don't want to run up their bill just to accomplish that, and I think the guidelines I outline are sufficient.
Dr. Sachs, the person who wrote the question describes a patient who has rapid cycling bipolar disorder, but principally depressed, very brief periods of mania, goes back into being depressed. How about chronic antidepressant for them? And going along with the same kind of question, the rapid cycling, whether they're male or female, may have much more depressive, a little mania, or much more mania, a little bit of depression, and how do you sort that out?
It's a very difficult thing to sort out what brief periods of any one mood state mean. And I'm not sure what the person asking the question may have meant by it, because brief period sometimes refers to a week or two. Sometimes it's this patient has been depressed every year, May and June, but 1 or 2 days in the week, they're clearly euphoric, each of those 8 weeks. What in the world do you make of that? That doesn't meet required criteria to be rapid cycling. That would, in fact, following the official nomenclature, simply be depression. That doesn't help us very much, because for the patient, when they're clearly euphoric like that, you said, certainly I wouldn't just leave the patient on antidepressants alone if that was their presentation. I would consider them to be bipolar, and I would consider this to be an atypical form of rapid cycling. And I would look first and foremost to maximize the mood stabilizing treatment that they got, and try to have at least 2 weeks where there are no euphoric periods before I would have them on an antidepressant. If I can do that, I feel a lot better starting out with very low doses and working my way up. For some patients, instead of calling them rapid cycling, I'll feel a little bit better calling that a mixed episode. And in those cases, I will again try to treat this as mania, and if I can bring it under control, great. If they're just left with depressive symptoms, I start an antidepressant or refer them on to ECT. And we prefer having these patients get bilateral ECT because the switch rate into mania appears to be lower with bilateral than unilateral ECT. Antidepressants are problematic. We would start with mood stabilizers for most depressed bipolar patients. It turns out, as we run treatment trials for bipolar depressed patients, they all require patients to be on lithium first. Very frustrating experience, because most patients who respond to our ads are not on anything. They have a clear history of mania, and they're depressed now. We bring them in, we start them on lithium, and within 3 weeks, 30% aren't depressed at all, and by 6 weeks, 50% aren't depressed at all. And so we lose, and we're hoping very much these patients will be able to enter the study, and even though that's open treatment, it means in 6 weeks, half the patients are better on lithium alone. I'd rather give that half the patient population the benefit of not being exposed to an antidepressant medication. That's really the lesson I think we've learned.
Thank you, gentlemen. Audio Digest Psychiatry is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1995.